It is 10:02. We will begin. Welcome, everyone, to the Synapse 101 webinar. We are excited to have you here. Here at Maricopa County Department of Public Health, we've been working with healthcare partners to conduct collaborative CHNAs over the past 12 years. Over this time, we've developed more sustainable and effective ways to work together. So today, we are excited to share how we structure the coalition, respond to any questions you have, and hear from you about the ways that you collaborate with healthcare. So meet our team. Here today we have Annie Damude and myself, but we also have Tiffany Tu, Jessica Francis, and our epidemiologist, Hamza Rafiq. So here's our agenda. We're gonna go through the Maricopa County landscape, phase 1, the Synapse Foundation, and then phase 2, creating effective Synapse cycles. So let's see who is in the Zoom today. We're going to have a poll come up, and you can just answer what sector do you represent. Be a couple questions, so I will give you guys a minute for that. There's some state health departments, public health nonprofit, local health department. Okay, we have someone from the academic education sector, primarily public health nonprofits. The population size of your service area mostly responded the tie for 300,000 to 1 million. So some of you do work with your hospital and healthcare systems to conduct your CHNAs. We have some I don't know, not applicable. And we see that some of you do work with your community coalition to conduct your CHNA. That's wonderful. Okay, I think that is enough time. I'm not seeing any new responses. Great, we can move on. Okay, so we will be using Menti throughout this presentation. You can join at menti.com and use the code, or you can scan the QR code here. We will be answering questions throughout, but if something pops up, you can go to this code and answer any questions you have there. That way we have it documented. Let us know if you have any questions or have difficulty accessing the Menti. Great. Now we will go through the landscape of Maricopa County and Maricopa County Department of Public Health. So the Maricopa County Department of Public Health, our vision is to create a healthy, thriving Maricopa County for all. Our mission is to increase the quality of life for our residents by collaborating with the community to develop and implement strategies, programs, and services addressing the emerging and changing needs of public health. Our core values are excellence, collaboration, resourcefulness, accountability, integrity, growth mindset, and inclusiveness. Maricopa County is the third largest health jurisdiction in the U.S. It's the fourth most populous county in the U.S. We have about 4.5 million residents, and it is 62% of Arizona's population. We also have 24 cities and towns, tribal land, and unincorporated communities. Here are some demographics. As you can see, we have about 4.4 million. Sex is about split in half. Majority of our residents are white and Hispanic at 53.2% and 31.7%. Most of our residents are in the ages of 25 to 44, about 27.7%, and English and Spanish are the primary languages spoken. So moving on to phase one, the Synapse Foundation, creating a collaborative approach for county and healthcare CHNAs. So we have your guide, the Synapse onboarding packet. So one of the tools that we have recently created is an onboarding packet, which serves to primarily onboard our new partner organizations, or it is really helpful when we have staff turnover at those partner organizations. But because we take a unified approach to data collection, but an individualized approach to reporting, we found that it helps to lay out all the stages of the Synapse CHNA work. That way we have a reference for our partners and they can always reference and go back to it. So as we go through the presentation, you can go to the link here or else scan the QR code and then you can find us. And we have these little packet pages in the top right. So whenever it's applicable, we have put those in there for you. So please follow along and we will give some CHNA background. So a community health needs assessment is a comprehensive data collection effort that strives to identify the strengths and needs of a community. The development of the CHNA helps to establish the priorities that the implementation plan is based on. So it is a requirement for nonprofit hospitals and FQHCs, federally qualified health centers, and community partners. The overall countywide CHNA also influences allocations of funds and resources for health improvement. So we have a little bit more information on packet pages 32 to 34. Next, so here we go. So this slide lays out how we structure community coalitions. Maricopa County is the convening agency that supports these two wings. On the left side here, we have the Synapse Coalition, which is made up of our hospital and healthcare partnerships that support the CHNA work, and members provide funding to the county for this work. On the other side, we have HIPMC, which is a community-led 15-seat volunteer steering committee and convenes quarterly meetings open to the broader community of Maricopa County. And so one of the 15 steering committee seats is reserved for the Synapse HIPMC liaison, whose purpose is to represent the healthcare and CHNA wings, so they represent both sides of the wings. And then we have Maricopa County at the bottom, which is the collective movement in how we brand our shared work together. You can go to maricopahealthmatters.org to learn more. We have our data reports there. We have more information on HIPMC and Synapse there. So please check that out. We'll move forward. So the Synapse Coalition. So some of our purpose and our vision is here. The Synapse Coalition is made up of a group of nonprofit hospitals and federally qualified healthcare systems that have been in collaboration for the past 10 years. The coalition works to understand the needs of the community and aims to improve the health of Maricopa County residents. So as you can see, the vision is to participate in a collaborative approach that identifies community needs, assets, and resources to ensure better health and equity for Maricopa County residents. So you can also find that on packet pages 7 through 9. And then we have more background on HIPMC. So HIPMC is a community organization that is made up of diverse representatives of those who live or serve the residents of Maricopa County. The members support the CHNA and the CHEP work, and their mission is to really impact real-time critical health issues in our community. So some of our partner growth over the years. So in 2014, the Affordable Care Act initiated the requirement for nonprofit hospitals to conduct a CHNA of their service areas. So two hospitals and one FQHC collaborated with NCDPH to conduct the first joint CHNA. By 2017 to 2020, the Synapse Coalition was formalized as a collaboration wherein member organizations provided funding to MCDPH to support the data collection and reporting. By 2020 to 2023, this cycle, Synapse comprised 4 hospital systems and 4 FQHCs. The 2023 survey collected over 18,000 representative responses, and Synapse was awarded a NACHO Model of Practice Award. In our current 2023-2026 cycle, we have 5 hospital systems and 5 FQHCs, and we'll be completing a total of 16 full CHNA reports and 14 data reports during this period. So here is a list of our Synapse partners. So as you can see, our 5 nonprofit hospitals are Banner Health, City of Hope, Dignity Health, Mayo Clinic, and Phoenix Children's. Our FQHCs, or federally qualified health systems, are Adelante Healthcare, Circle the City, Native Health, Neighborhood Outreach Access to Health, or otherwise known as NOAA, and Valleywise. And then we have our philanthropy organization, which is Vitalist Health Foundation. So we have monthly Synapse meetings. So the coalition holds these monthly meetings that encourages collaboration. We share updates and information, really provide pathways for networking and reaching out and cross collaboration. So right now we do mainly do virtual meetings, but we are pushing and striving towards incorporating more of in-person meetings. The Synapse Coalition is also encouraged to participate in those HIPMC quarterly partner meetings. So the benefits of a collaborative partnership with healthcare is to eliminate duplicative efforts, create an effective, sustainable CHNA process, build stronger relationships between healthcare systems and public health, identify opportunities for joint efforts to improve the health and well-being of Maricopa County, and help health systems, public health, and community partners focus on available resources to address the community's most critical health needs. So some of the successes of that collaboration is the distribution of over 12 million to community organizations through the CDC Health Disparities Grant, the development of the Voices of Maricopa County dashboard, and then the supported vaccine uptake strategy in Maricopa County, and facilitated data-informed funding to local community organizations via foundations, community benefit dollars, and resource allocations. So I did see some questions come through the chat, but as a reminder, any questions you have, you can submit them here. Let me check the chat really quick. Oh, okay. So we just have Annie. Annie, was there any questions in the Menti so far? Did anyone?
Yeah, it looks like so far just a few process questions. So if we'll have access to the webinar slides, which we do plan to send out in the next few weeks following this session, and then an updated link to the packet. So if anybody is having issues with accessing the onboarding packet, please let us know. But I think those are it for that section. But yes, as a reminder, please submit any questions you have. We'll try to get to them as they come in, but also we'll have time at the end.
Yeah. Great. Yes, we will keep looking out for those. And now I will pass it over to Annie.
Hi, everyone. So good to be with you today. My name is Annie Damude. I'm our Community Health Assessment and Impact Supervisor and have the great privilege of leading our Synapse Healthcare Coalition, which Pearl has done a wonderful job of setting that foundation. So I'm imagining that many of you are curious how we coordinate all these partners, how we complete all these deliverables, how we make it all work with a fairly lean team. So we want to get into this next section, creating effective Synapse cycles. So sharing our tips and tricks for developing a sustainable coalition with clear purpose and funding. So we can head to the next slide. So just as a reminder, the vision of the Synapse Coalition is to participate in a collaborative approach that identifies community needs, assets, resources, and strategies toward assuring better health and health equity for all Maricopa County residents. So, as we look at all of our different healthcare agencies serving the Maricopa County community, we know that there's a lot of overlapping service area. So it was really important for us to really unify that data collection so that not only are we all kind of looking at similar data from the community, but we're avoiding that duplication. We're not having just small pockets of data collection with measures that are impossible to, relate to each other. So that's been a big effort of the Synapse Coalition. But then I'm going to get a little bit more too into how we then take those results and implement them in each of the healthcare settings. So next slide. Let's talk through the different phases of our membership in the Synapse Coalition. So the structure is that we have our partners. They have 3-year contract cycles with us as the health department. So as you may know, the nonprofit hospitals and FQHCs need to conduct a CHNA every 3 years. But for us as public health, it would not really be sustainable if we had the partners just involved or just paying for that, 8 to 12 months that we're working on their report. So this is one, I would say one key to success is having these contract cycles be 3 years. We have the partners pay the same, they pay in equal yearly installments based on whatever their fee is that we'll get into in just a little bit how we determine that. But phase 1 typically includes the orange is a partner specific activity and green is a coalition activity because there's a lot of things we do united and there's a lot of things we do independently. So we work with each of our individual partners to complete the Synapse onboarding tasks, make sure we understand who's going to be involved from their organization, make sure that they're up to speed on what expectations are, that we know what their marketing requirements are and their deadlines, those kind of things. As a coalition, we work to collect primary data. So that means we collect community health surveys, focus groups, key informant interviews. And we analyze and report on the overall CHNA data. So instead of, I'm seeing a question come in about, do we create our own CHA or adapt their survey? So we know that for many of our partners who've kind of joined in more recent years, they're used to conducting their own CHNA survey of their own partners. But one thing that we do is we work together to have just one survey that goes out. So we do get we get feedback from our Synapse Coalition as well as our HIPMC Healthcare Coalition. And just to ensure that the questions that we'll be asking will be relevant to the health system. But also we do take that overall public health approach. We know that a lot of the other data sources we pull in, hospital discharge data, death data, are very medical focused. And so we ensure that our CHA survey really has a lot of those social determinants of health, personal experience, that type of data that you're going to really get the most out of when we're asking our community members. So we have one survey that goes out that all of our healthcare partners use the results of. I'll get into a little bit more about how that united effort has really worked out well, but that is definitely a foundational approach for us as the Synapse Coalition. What we do then independently in phase 2 is, so like I mentioned, we're using the same community data for all of our partners. However, we compile and analyze partner primary service data. So some of our partners, like the Mayo Clinic or Phoenix Children's, they would consider their primary service area technically not only the county, but probably the state or even the region because of the specialty services that they provide. But a lot of our federally qualified health centers or our hospital systems that have many different branches, their primary service area is that 75% of patients, the zip codes that they're coming from. So what we do is we look at hospital discharge data, death data, we look at diseases of morbidity and mortality in that service area to help those healthcare systems come up with kind of a profile of what's going on in their community based on the numbers. Then my favorite part, which is our partner prioritization and data presentations. So we work individually with each of our partners to determine the best method to really hone in on those priorities and help them select what they want to focus on in the next few years. So some of our healthcare systems have had community benefit coalitions and really have kind of these established structures where the community comes together, and we, during that phase of the cycle, will come and we'll present, we'll lead facilitated activities, and we kind of just slot into what they have. But many of our partners, like our smaller FQHCs, this might be their first time doing a health prioritization. So what's really neat is that we work with them individually. We say, do you want to have do you want to work with, your patient advisory committee? Do you want to work with your board? Do you want to pull in members from the community to see this data and give feedback? So we really have a tailored approach for each of our health systems. What's neat though about having, as Pearl mentioned, we have 5 hospitals and 5 FQHCs working with us this cycle, is that we've gotten to explore and experiment on a lot of different ways. So we can do these virtually with using Menti and Jamboards and murals and having folks, get in and brainstorm. We can do them in person with sticky walls and voting and those kind of things. And so we do this often enough that we're also able to to help advise and create these structures for newer partners. So then we come back together as a coalition, and this is the piece that identified a shared Synapse priority. This is more of a one-day ambition. I'll get into it a little bit more, but we were working on a joint Synapse HIPMC strategic plan. And one of our ideas there is that we know most of our partners already choose within this same top 6 to 8 health priorities, right? You typically have your mental health and your cancer and your chronic disease. But because we do an individualized approach for each of them with their prioritization, we don't have a unified health priority across the health systems. Now, we as the county, we have our own CHA and our own health priorities, using the same underlying data and involving a lot of these same key members to come and provide input. But one idea we have is identifying a shared priority and language so that each of the partners, as they go about their implementation strategy, can really leverage some of the same resources and kind of build out those implementation strategies. But again, we'll report back in a few years. That's aspirational at the moment. So back to our partner-specific activities, and these phases occur at different times. I'm going to show you in a few slides, I'm going to show you a kind of layout of when these different reports are due, and you'll see we are always in one of these phases, except for the collecting primary data. That happens once every 3 years. But for each of the other partner specifics, it's always happening. So we do develop, and I see a question here, who writes these reports? How do we ensure one reflects data unique to their service area populations? So we, as the health department, our team, myself, Pearl, Tiffany, Hamza, we write those reports. So what we do is we ensure that they're specific to each of the different hospital and healthcare systems because we're working off of the different primary service data. So you may have a couple partners whose reports are due in the same year, and if they both use the county overall as their PSA, their underlying data reports are going to look pretty similar. But we go through that unique prioritization process with each of them. We also have the opportunity for them to pull in their own data. And so those are ways that you're not going to see 2 reports that are identical. Some of the content, our methodology, those are going to be united because we do that in the coordination, but the rest is very unique. And so one of the benefits of us being able to, again, as I mentioned, with prioritization, working with many partners is we do have some great templates, but a lot of times our health systems come in and they have a template already. So Dignity Health might have a different template than the Mayo Clinic. And so we're working to develop those reports with the data into those templates. Another thing is data is different year to year. So if one of our partners, they have their report due in 2023 and one of them has it due in 2025, even if we're looking at the same service area and the same indicators, the data we have access to is different. So those are some different ways that you can, that we ensure that it's, working off of like unified and comparable data, but it really is tailored to each partner. Preparing for the upcoming CHNA, huge task. We work on our outreach plan. We work on our data tools. Then independently, the partners create their strategic plans. So that's one area that they are responsible for. Individually, we are available to come and present updated data and be involved. We love seeing what comes of this data collection. And then we renew contracts, and that takes a really long time because as a government agency, we have a lot of steps we go through, and as a healthcare agency, they have a lot of steps they go through. So that is always something that we want to start earlier. All right, heading on to the next slide. I want to kind of give some examples of how this combined data collection approach has been really successful for us. So we collected over 18,000 surveys in 2023 for the CHNA survey. And this was an effort led by the health department, but we worked with our Synapse coalition members. We worked with, we were able to provide funding for 23 community-based organizations to go out and survey focused populations. So it was a huge effort, 4 months of data collection, but with incredible results. So we had almost 1,000 surveys conducted by veterans, over almost 1,400 from individuals living with disabilities, over 2,000 for LGBTQIA plus individuals, and over 1,600 refugee, immigrant, and migrant. We had representation across the county in our 5 different regions that we split them up into. And these are numbers that we haven't seen before. We maybe have had a high number of surveys, but they've been primarily in our white women population, mid to high income. And so this past cycle, we really did a very concerted effort to make sure that our data was more representative of folks across the county and in different communities. So next slide. In order to do that, we set different targets. So we had different goals for each of our regions, for each and for the county, by race and ethnicity, by population characteristic that we wanted to hit to ensure that we'd be able to publish that data and really have that robust sample. We do collect data in a convenient sample format, but I will say it is not. We do our best to ensure that it is not only the most convenient folks who take the survey. Anyone in the county who is aware of the survey is eligible to take it. And however, we do a lot of very focused outreach to make sure that folks who, again, historically haven't been able to be represented in this data are. That meant that this past year, we provided our survey both in digital and in paper format in 14 different languages. We had over 5,000 of our 18,000 surveys done in paper format. That really increased accessibility. It also increased the amount of time it took for us to enter data, but just wanted to give some of those examples of ways that we've kind of tried to adapt to make sure that we're getting really good, robust data coming in. All right, next slide. So how have we increased over the years? So our first time doing a coordinated CHA in 2012, we had almost 1,000 survey responses. And then again, we've had over 18,000 in this most recent one. So increasing the kind of some of the different accessibility features, having virtually and paper, a regional approach, additional languages, those have all been key elements to helping see this number increase. And again, we're excited to see the number increase, but what we're more excited is that the representation, the demographics that we're seeing come in better match the population of our county than we have seen in previous cycles. So next slide. All right, so what do we do once we have that underlying data? This is an example of what we end up showing our partners when we do their prioritization. So we often have county epidemiology data, for example, and this was a bit of an older, we need to update this now that we have our newer survey. But we have, so for example, a stat from 2019 about mental and behavioral health ranking for inpatient hospitalization in emergency department. We'll compare that to what we're seeing at the national level. Our 2021 community survey showed that almost 36% of participants said their mental health in summer 21 was worse than before 2020. And then a quote from a focus group participant just about it. It's really difficult to not be able to deal with depression in community because of isolation due to COVID. So just some examples of how we really try to bring that all in together. So we're not just focused on hospitalization, we're not just focused on quotes from community, but to really give that kind of 360 view. This has been something that has been very meaningful for our community members, as well as for our folks who work in hospital and healthcare. A lot of times these stories really resonate with what people see day to day. Next slide. Here's an example of us up at a sticky wall, facilitating some of these prioritizations. And so virtually, sometimes we'll do things like a word cloud. Based on the data, what do you see in your community? We'll see mental health, obviously, is really kind of rising to the top. We'll have communication and facilitate these conversations. So getting in a room with folks from that the healthcare system has identified to talk through data, to prioritize based on certain criteria. That's another thing, is that we've worked on different criteria matrix. So things like feasibility, impact, scope, those type of things that each of our different partners can kind of tailor to make sense for them. Because it's really difficult to get in a room with folks, show a bunch of data and say, now what? So we do our best to continue to really provide kind of that framework for them to approach this data, feel confident making decisions and recommendations of what their organization is going to focus on. So I'd say that's another one of our specialities, and something that we've really kind of learned through trial and error, is how do we come to health systems and communities with data, and also kind of setting them up for success to make these decisions. All right, next slide. And when it comes to developing the reports, so that's another area that we've really improved over the last few years is, the CHNA baseline is a requirement. You have to have all of the different components that the IRS and the HRSA requires. But we also want these to be useful. And a lot of our partners want these to be materials that, their patients would be interested in, that can help them as they're, applying to different grants and things. So for one example, this is a profile for a federally qualified health center. So we'll do like 2 pagers for each of the different locations of the FQHC, showing the demographic profile, showing the results from the survey, showing, of the top 3 issues that they selected, what were some of those key data points. And this is an example on the right of how we can really show prioritized health needs, how they've changed over time between our different surveys, because we do like to do that longitudinal approach as well. So as I mentioned earlier, sometimes our healthcare systems have templates they want us to work with. If they don't, we have some templates that we've developed. This might blow your minds, but we do all this in Microsoft Word, which is quite an ordeal. Yes, Pearl is one of our Microsoft Word wizards, and it's a labor of love, but that's also been one of the more accessible formats that we've been able to use, especially for partners being able to give notes and things. I do see a question come in about, do we use a framework to guide the development of these phases and processes? Yes, we do. So the MAP framework is one that we've been using for many years. As many of you maybe know, MAP 2.0 came out in the summer of 2023, right when we finished doing our survey data collection. So this past year, our team has been working really hard to catch up with some of the guidelines of MAP 2.0 while also continuing out our process. So we've done a lot to compare the work that we've already done with some of those MAP recommendations, the MAP 2.0 recommendations, which has been super helpful. And we're so excited for this next upcoming cycle to be using more of those. Like the starting point assessment is going to be super helpful, the community partner assessment. Some of those we just weren't able to fit in this cycle, and that's okay. We know MAP 2.0 is something that can be tailored to each organization. But yes, that is typically the format that we do use kind of for some of those guidelines. And we're working to make sure that we can follow those processes even better. All right, next slide. So this is where I want to share with you kind of the fails and the comebacks that we have had. So here's 4 areas that we've struggled and ways that we have adapted to respond. So one was overlapping partner deadlines. As we mentioned, with the number of reports, the number of partners, it's extensive. And so oftentimes we're really kind of dependent on when the healthcare facility has their deadline. Everybody has different IRS and HRSA deadlines, and we have to work with that. But when we work enough in advance, we'll know if 5 partners have the same, like the same deadlines in the same quarter, we can grab a few of those and try to work earlier on those reports so that not everything is jammed at the same time frame. So that's one thing, staggering them across the 3 years. This is the big one, reviewing timelines at every meeting. So I'll talk about funding a little bit more, but the way we provide very competitive funding, it's a lot less expensive to go with us than it would be to go with a consultant. We have a lean staff, and the only ways that this happens is that there's an understanding that we share time with our limited staff. And so once we agree to these timelines with the partners and we have everything staggered, we make sure that we're reviewing those deliverables every single time we meet, so that in case there's turnover on the partner side, that's going to majorly impact our timeline. We need to be aware of that, and vice versa. If there's something with the data that's delayed, we want to make sure we're in communication. And then splitting partner assignments between staff. A handful of years ago, we kind of had the same few people that were leading, communicating, developing the reports for every single partner. And as we've grown, that's just become impossible to keep all of those different timelines and communications organized from one person. So Pearl and Tiffany each are split, and they each have 5 partners that they're responsible for communicating with, coordinating timelines, and they provide the lead on those reports. It's still a ton of work and a ton to coordinate, but it also helps us to see what is that ratio of partners to staff that we need to make sure that we're maintaining quality and sanity. Another issue we found was an unclear contracted scope of work. So the contracts, I've been working on this project for the last 3 years. Contracts I inherited were fairly general. We had a few bullet points, collect data, provide reports. And that just was really difficult for us to set expectations, not only for the partner to feel that they were getting what they needed, but for us to know kind of what those limits and boundaries were. So since then, we have very robust contracts with both party expectations detailed. We've gone from a few bullet points. Now we have 6 pages of a scope of work, county will, healthcare partner will. And that is so helpful because it helps indicate to, we need 4 weeks notice if XYZ is going to change. You know, we commit to providing responses in this amount of time. Here's the primary service areas and the number of reports. Because otherwise you can spend a lot of your cycle just trying to negotiate how many reports you're doing, and having that up front just really paves the way. All right, so then next would be limited staff capacity to support Synapse and the overall county CHA. Believe it or not, we've had the same folks responsible for doing all of our Synapse partner deliverables and leading the entire countywide CHNA. And as you can imagine, it's a similar skill set, but there, especially with more partners, that timelines intersect and things get a little bit untenable. So one big thing that we have learned is to hire a CHA coordinator as a cycle round position. So we have our newest addition, our CHA coordinator in the team. And what is amazing is that this person is going to be able to ensure that we are following our MAP 2.0 framework, that we have kind of that cycle round support. Because again, you all know it's not just once every 3 years and then you forget about it. You need that full-time focus. And that allows for our Synapse specialists to be able to continue providing that focus and care to our Synapse partners, as well as support the CHA, but not be the primary ones responsible. And then to develop clear roles and responsibilities 1+ year before CHA launch. So we're just getting out our results now from our 2023-24 data collection. And we already have a lessons learned and kickoff meeting in like 2 months. So that is something that we have learned, is that start early, especially when you have a big service area and you have a lot of different folks that you plan to pull in. Another challenge we had was with document sharing and continuity and staff turnover. A few years ago, we were doing everything just via email. Sometimes your document's too big. Also, then you have 2 people turnover and you're starting back at square one. Something we've done is to develop SharePoint or Google Drive for each partner. And that houses their timelines, their contract. It houses any documents we're working on. So much easier to go in and have them provide edits and revisions than us emailing back and forth version 2.2.1.7. So that has been helpful. And also it all exists there. So not only if there's new staff on the healthcare side, but also from cycle to cycle, they now have all of that coordinated. We have different SharePoints for every single partner. So that is completely unique to each of our partners. All right, next slide, please. So let me take a moment to look at questions real quick. Getting so many responses.
Another thing to mention too is we do have a shared Google Drive for all of the coalition members as well. So that also houses our meeting minutes, PowerPoints, any information they would like to share, contact information, and any other materials that they would like to put in there.
Yes, that really helps so that if folks miss a meeting or something, they can go back and see the recording. Yes, and it helps us to stay organized too with what all we've shared out. Thank you. So yeah, staggering deadlines. So this is an example of maybe what our current cycle looks like, where we have FQHC reports and hospital reports kind of due throughout. That's up on top. On bottom is our CHNA major steps. So you'll see between year 2 and year 3, super busy, a ton of reports, a ton of, and this is just the report, you know, knowing that it takes at least 6 to 12 months before the report to be working on data, communicating with partner, doing prioritization. And so this kind of helps us to see just like our capacity. And again, in advance, we try to pull partners earlier when we can, to the extent that it works with deadlines and data availability, those kind of things. So next, I'm just going through each of these different kind of examples of the tools for success. So robust contracts and expectations. Let me talk a little bit about funding here. So one thing that we do is our funding is based on the amount of reports and the amount of different kind of data analysis slices that we have. So one hospital system might have one primary service area and have one joint report. They get our base package. Another healthcare system might have 5 different locations. And that means that there's 5 different sections of that service data we're crunching. It means that we have 5 different reports we're creating. So they're going to have a base package, but then with add-ons. So there's a monetary amount for each of those additional reports and data analysis efforts. So that has been really helpful for us to ensure that we're providing, you know, kind of that an equitable approach from partner to partner, but also that we are able to meet our needs with our staffing as well as our data collection. So I see some questions on kind of the budget. So we typically have, let me see. Okay, so we usually say Synapse partners, they are responsible for about 40% of the funding of the CHNA and overall work that we do. Health department kicks in the other 60%. That was a few years ago, so we'll need to do another like market assessment just to make sure. But that means that we're pulling in many of our staff, and I'll show you in just a minute kind of how our staffing model is broken down. But many of our staff are funded through the health department. And you know what? I'm about to get to that in a moment. Let me stick here with the contract. So just kind of showing some of these different items that are required, or not required, but that are provided. So we also have our partners, they're eligible to ask for additional strategic support and epidemiology analysis time as a perk. And one thing too is that we have, you might see in this example here. So for decisions requiring consensus, each of our health systems gets 1 vote unless they function as like 2 different health systems. And so that's also a way to make sure that our really big hospital systems and our smaller FQHCs are able to have similar levels of participation. And we don't want it to be the case where you have one of our sectors kind of dominating some of those decisions. So that's also an intentional effort. All right, next slide. Hire a CHA coordinator as a cycle round position. That's the quote. That's the message. So here we go, the 60-40%. So these are our 6 main staff who work on CHA and Synapse. So of those, we have 3 staff who are completely funded by other sources. So that typically is different grants in the health department. We have the fee fund, which is what the Synapse partners pay into. We have 1.59 FTE funded by fee fund. We also can use, it's a little bit more of a flexible fund, so we can use it for software, survey giveaways, meeting expenses, etc. And we were able to increase that price by 20% from last cycle to this cycle, and we retained all of our partners. So that's one thing, is we want to, because it is a collaborative, and because we do have FQHCs at the table, we want to make sure it is affordable to be part of this collaboration. But again, also that we're kind of able to staff and continue to do this work. So at the moment, our philanthropy partner does not pay into any of these specific roles. However, they provide kind of that additional support. For example, if we need assistance with hosting a meeting or providing a facilitator, providing food, that's really where our philanthropy partners steps in. I think there's lots of, there's lots of opportunities to continue to have the philanthropy wings be involved. But right now it's mostly each of the health systems. They pay annually into this membership. And again, if within the first 6 months of their 3-year cycle, they have their CHA report complete, they're still participating in meetings, they're still paying their annual fee for the next couple of years. And that really maintains buy-in and continuity. Let me see I saw there was a question about staffing. Especially interested if you have statisticians, data informatics, or survey research experts. So as you'll see here, we have 2 community health impact specialists. So that's a role that Pearl plays. So it was really kind of all things communicating with partners, project managing, developing reports. So definitely a data background. Our community health epidemiologist is the main one who works full-time on pulling all of the underlying data, advising on interpretations, working on our survey analysis. We do have a broader epidemiology team as well. And there's many folks there who do work on kind of that data informatics that we can kind of pull in as needed, especially around survey development time. So that is one thing that is a benefit to being in a larger county, is that we do have kind of more staff with more specialties that we can kind of pull when needed. But each of these 6 roles are like, they're involved in this work all the time. Health department funding. Does it come from your health department budget or funded? Yeah. So kind of, again, as that explanation, pretty much all of our folks working on this are either funded by the fee fund from our partners or from other grants. Because this work supports the needs assessment of the entire county, that is, it's very justifiable to have this work intersect with other grants as well. All right, moving on, because I want to make sure we have enough time for those questions. So here's an example of the SharePoint Google Drive where we pop in, here's our meeting minutes. It's really important that expectations are clear. So we're responsible for the meeting minutes, and they're always available immediately in that notebook on the SharePoint. CHA deliverables, so different drafts of things, and then the contracts that we all have kind of that shared reference to look at. So there's a question, are there other project management tools and platforms you use? For example, Asana, Monday. We're working on that. We have had many different ways of structuring this. We've had Trello boards, we have Excels, we have individual timelines. We are literally right in the process of trying to unify that together. We are looking at using monday.com for that, but that's another, let's check back in a year or 2 and talk about how that's going. Also, if you have advice, I would love to hear it. Feel free to drop that in the chat if you've done similar projects. All right, next slide. Future goals. I briefly mentioned we're creating a Synapse HIPMC strategic plan. Let's get our healthcare partners and our community-based organizations even more on the same page, because we know that those services are really interlinked. So we have been able to allocate some funding, and we have a consultant group working on that with us this fall. We're looking to onboard more partners. There's other nonprofit hospitals, there's other FQHCs that are out in our county, and we would love to have them to join us. Continue improving facilitation. Like I mentioned, we have a lot of different ways that we can work with partners, and that's a big area that we always can strive to improve. And then technical assistance for other jurisdictions. So like this, I know a handful of you are coming from other states. We love being able to share what we do and learn about what you do as well. So I am going to make a little plug, is that we have an evaluation that we're going to send your way at the end here. And one of the ways that we can kind of justify doing these sessions and helping. We do a lot of one-on-one time with other jurisdictions. So there's absolutely the opportunity if you want to schedule time with us. If you want to head to the next slide, Pearl. Check out our website, but you can also schedule time and we can chat more if you have individual questions. But in the evaluation, it really helps if you can maybe share a few sentences about like if this was useful for you or what ideas you might have as a result of our time together today. And again, that just helps us support being able to create this time. So yes, check out our work and also would love to hear from you all through our evaluation. But another plug for you is that next slide, we have a CHIP 101 webinar later this week on August 8th. So last Thursday, we actually did a CHA 101. I see I had some questions about how are you getting so many responses, what's happening? And that's what we covered actually in our CHA 101. It was recorded, so that will be sent out. And so I will just say, stay tuned. We'll be sending that out. I'm trying to think what would be the best way. If you're interested in getting that information, maybe if you want to throw your email either in the chat or in the Menti and say, send me the webinar. But this one will be all about the Community Health Improvement Plan. And we are right in the middle of making it. And so if you're curious to learn what we do, if you live in Maricopa County, want to be a part of it, we would love to have you attend this webinar on the 8th. All right. I know I didn't leave a ton of time for questions, but I think we've hit most of them along the way. Let me just double check.